Hi everybody, welcome to 212. This is the first lecture in a series. There'll be 3 for me, of course this is Cindy, then you'll get some from Megan as well. This is all for exam 1. We're going to do a little review from 112. You'll recognize quite a few things and we'll build up on some of that. This first part, drug regulation, it's part 1. Also you'll see pharmacodynamics and pharmacokinetics, and we'll go on from there. Okay, so some important pieces of legislation. They're listed here. Food, Drug, and Cosmetic Act of 1938 that amended and updated what happens with companies. So the drugs had to go through testing and review, and that was important. We kind of hit on that in 112. Then this Harris-Kefauver Amendment in 1968, where drugs had to be safe and they had to do proving that the drug was effective for what they said it was effective for. The Controlled Substances Act, that would be to control narcotics, and they made up the schedules of narcotics. We'll go over that a little bit. Then the Food and Drug Administration Modernization Act and the Best Pharmacotherapy for Children on the Pediatric Research Equity Act also. Those are a couple of things that happened in the late 90s and had some fast tracking and approval extensions for those companies to help them approve medications and get them out there on the market. Also, this was for medications that were really needed, not just things that were going to profit the company. So don't worry about this too much. This is just a little review. We're going to go on to controlled substances. So there's these different categories for controlled substances called schedules. There's Schedule 1 through 5. They're all listed here. They're available on the U.S. Department of Justice Drug Enforcement Administration. You see these websites down here that I put on there. You're welcome to go check those out if you're interested. That's where I took this from exactly. Okay, so let's go to Schedule 1. The medications in this category have no accepted medical use, and they have a high potential for abuse. This includes things like marijuana, even though now we're hearing a lot more about some limited medical uses, but Schedule 1 drugs currently have no accepted medical use in the U.S., and there is a lack of safety for their use. They must be taken under medical supervision, and they have a high potential for abuse. I don't think there's any must be under medical supervision because these are not accepted for medical use. So that's just a typo in my reading to you, sorry. The main thing you want to remember is this is the one where marijuana lives, and this Schedule 1, they're not currently accepted for medical use, and they have a high potential for abuse. Heroin, LSD, cocaine, those are kind of things that are in this category. So Schedule 2 drugs have accepted medical use but have a high abuse potential. Then there are severe restrictions, and they can lead to psychological or physical dependence. The prescription has to be written or through the approved electronic prescribing process that goes directly to the pharmacy. They cannot be called in, and there's a lot of regulation on these types of drugs. Some Schedule 2 drugs are Duromorph, codeine, MS-Contin, Dilaudid, and Ritalin. Schedule 3 drugs have less risk for abuse than these Schedule 2. Some of the Schedule 3 drugs are Fiorinol, which is aspirin, butalbital, and caffeine. Those 3 things make up Fiorinol. Vicodin, which is acetaminophen and hydrocodone. Those are just a couple. So this category, there's a lower or moderate physical dependence issue on the Schedule 3s, and there's less restriction on the prescription writing and refills for this, so not so bound by rules like Schedule 2. Then on to Schedule 4 drugs, they have a low potential for abuse compared to Schedule 3. This is where phenobarbital, Ambien, lorazepam, some of those benzos, they live under the Schedule 5. They live under Schedule 4. So phenobarbital, Ambien, lorazepam, some of those benzos, that's where they all live under Schedule 4. Schedule 5 drugs, they have low potential for abuse relative to the substances in this schedule. Let's see, so as you go down this list, they're getting a little safer and safer, less abuse and less needing to be monitored or watched. Schedule 5 are preparations with limited quantities of narcotics, cough medicine with codeine, cough suppressants. Some states it might just be behind the counter on these types of medications, and other states you have to have a prescription for those. So these two websites on the bottom, the first one I think is if you're interested in looking at the difficulty with prescription writing and refilling on the different schedules. We're going to go ahead and go to our labeling on this next slide. Okay, onto our label here. What I wanted to show you is this Percocet, which is oxycodone and acetaminophen. It's the label. It's showing it's a controlled substance category. So that's what the standard is, to show how, where it says controlled substance and what category it's in. So you see the big blue arrow where it's pointing letter C for controlled, and then it's in category 2. All right, let's go on to over-the-counter drugs. We know there could be safety issues with this because over-the-counter drugs are everywhere for people to get. It's important for us, since we have the knowledge. You all took 112 already, and you have a lot of nursing knowledge. We have that role to teach patients about risks with all drugs, how to read labels. It's an important part of teaching, especially when patients are taking multiple medications at a time. We have to assess and stop what we're doing and say, you know, this doesn't make sense that they have this many medications on board. They don't understand, and you might need to tell the provider that this patient might be on 2 of the same kind of medications. Did you realize that? Patients aren't going to know any different, and we are advocates for them, so that's part of our role. Consumers, patients, might think that all over-the-counter drugs are safe because you can get them anywhere. You can see that from these statistics of, they're a little bit old, but 79 to 81% of adults use over-the-counter medicines as a first response to minor ailments. They don't have to pay for the visit to the doctor. They can treat themselves at home to be healthy. So it's safe for them if they follow the directions carefully on the package. They may be mixing prescription drugs with over-the-counter drugs and not realize that they're going to have a problem. Right here is the active ingredient. It shows you the generic name on this right here. So that, well, this whole label gives you a lot of information. Its uses are all right here. Kind of a aches and pains, minor. Then also it tells you some warnings. Contains acetaminophen, severe liver damage. It gives you the overdosage, so don't go over this in 24 hours. Or take with other drugs containing acetaminophen, which is what I meant by you being in the advocate and noticing they're on a medication prescribed that already has acetaminophen, plus they've been taking this over the counter on top of it, and that could double up and make too much for them. It also shows not to use with other drugs right here, or if you have an allergic reaction, what to do. Here's some symptoms of the allergic reactions. It points out if you're drinking 3 or more alcoholic drinks every day while using this product, you can have liver damage. So this is where it's important to point out that patients at home have this information, or even just people that we know. Okay, another part here, it has the precaution for pregnancy, what to do if you have pain that's getting worse or lasting more than 10 days. And also it tells you how to take it. And here's the list of active ingredients. This is where it's important for those people who are sensitive to generics versus name brand. This is where the differences might be. With a generic, this inactive ingredient list might be quite a bit different. This part will be the same, this active ingredient, but this might be different. And for people looking out for their sensitivity issues, this is where you can point out, we'll look at the inactive ingredients of that generic versus the name brand. Okay, we're going to talk about some pharmacokinetics now. This is how you get the drug from whatever route that you're administering it and its movement through the body. Remember that we have these 4 ways to get the drug from the route to the body. We have absorption, that's from the site of administration to the blood. Most things we're going to be taking orally, so it has to start to dissolve or diffuse either from the stomach into the blood, or it might be through the skin topically or a patch. the skin has to absorb it in order to get it into the blood. It might be that it's all going to the small intestine before it kind of hits the blood flow. And then distribution is how we get it from the blood into the interstitial spaces in the cells and its actual targets. And then, how it's going to work for the body. Metabolism is altering the drug in some way to either get eliminated or to make it more effective by breaking that drug down and turning it into a metabolite. This is an enzymatically mediated change. Sometimes the drug has to be changed in order to even have any therapeutic effect. Remember from 112, that's called a prodrug. Clopidogrel is one of those. It doesn't have any therapeutic effect until after it gets metabolized by the liver. Then it starts to have antiplatelet effects. So metabolites are the drug product after metabolism actually happens. And then excretion is the movement of the drug or those metabolites out of the body. Changing the drug and getting rid of it involves both metabolism and excretion. They work together. Excretion really explains the elimination of the drug, and the arrow is just supposed to be showing you that both of these categories work together to get to elimination. There's a lot of things that influence each of these categories, and we're going to talk about some of those factors on the next slide there. Factors that affect absorption. So we know a drug is going to try to get from the route you administered it into the local blood flow, and that's going to have an impact on which area the local blood flow is going to be at. So if, say, it's going to dissolve in the stomach, and the pH in there is going to influence that. Also, if you put it on the skin, it has to get through the skin and into the system. So if it's a liquid versus a pill, a liquid might be dissolved quicker. So there's some factors that affect absorption there. It has mostly to do with oral consumption, what we're talking about with the dissolution rate. Like the pill going into your stomach, getting it all the way to the small intestine, if that's where it's made to be absorbed, and you have to have the dissolution happen there. There's a lot of surface area in the small intestine, and so that's going to affect absorption. We have a lot of villi all in the small intestine and also some in the stomach, but the small intestine has a huge surface area. So think about that patient who has had a small bowel resection and how that's going to affect absorption. If the blood flow is faster, you're going to have a higher concentration gradient, so that will affect absorption. If the patient is hypotensive, you're going to have decreased blood flow, so it's not going to be absorbed as quickly wherever it needs to be going. There may be slow absorption with an IM injection. IV route is, of course, the one that's most effective and quickest in getting medication right into your blood and absorbed. And then we have high concentration on one side and low concentration on the other. That makes diffusion of a drug go across from high concentration to low. So places with good blood flow are going to have faster diffusion across this gradient. Then you see in the little picture, lipid-soluble drugs can cross easily. The cell wall has, lipid-loving or whatever, so those lipid solubles cross easier. Then with ionization, drugs that are non-ionized do cross well. Drugs that are ionized do not cross well. Large molecules don't cross well. And then some water-soluble molecules or drugs have to sometimes pass through channels, so that takes a little more effort to get them across. So here at the bottom, an acid drug in a basic media, that would be ionized. And an acid drug in an acid media is non-ionized. So the acid one is going to be the more favorable one for absorption. And then we're going to go on to some factors affecting distribution. Okay, that's when the drug goes from the blood right to the cells or to the targets. It's going to go through capillaries, getting to the cells. This is largely affected, again, by blood flow to the tissues. Some tissues that do not have good blood flow, like joints, bone, muscle, and fat, so the distribution is going to be slower. Also, if there is a big abscess with purulent drainage, it's not going to have as good a blood flow, and that area with the drainage in it, it won't be able to get the drug to that cellular level, and the drug's going to have to fight to get through that drainage. So you would have to have that area cleaned out or debrided in order to have good healing. Big organs like heart, liver, kidneys, they have really good blood flow, and you can see that there's differences in the blood flow to tissues. And some barriers that we do have that affect distribution also are the blood-brain barrier. There's endothelial cells, and they have really tight junctions. Ethanol and lipophilic drugs can still cross, but other kinds aren't going to get through because of these tight junctions. And then we have the placenta. It's also a barrier, but not as good as the blood-brain barrier. Lipid-soluble medications can still get through, and some other kinds of Schedule I medications can get through too. So it's not a great system, just a type of barrier. Protein binding is the percentage of drug bound. So if your patient's malnourished, they might not have enough protein for the drug to bind with, so it's going to be floating around in the blood, and they might have risk for toxicity. It won't get distributed, it's just floating around. And if you're taking two drugs and they're both protein bound, that's competition. So until some of the protein bound drug bumps off, the other drug can't get on. So one or the other you might be toxic with because it's hanging around so long waiting to get protein bound. The advantage that's used with protein binding is that the longer duration of effect will be occurring because it's floating around in there longer. Warfarin, which is Coumadin, the blood thinner, is one of these. 98% of it is protein bound, and so it has a long duration and a long half-life. It works for days after administration, and it's easy to get to the steady state. But the downside is that you have increased risk for toxicity, and you have to check the PT-INR levels. That's prothrombin time. It's evaluating the coagulation time, or the bleeding time, how long it really takes to make a clot. That's what you're actually looking at with that PT or PTTINR. Sometimes they do other tests too, but with the warfarin, it's a PTINR. And then we also need to talk about tissue storage. Fat-soluble drugs are going to be stored in fatty tissues, and their slow release will give a long duration of effect. Marijuana is one of these, which is a fat-soluble substance and can be stored in fat tissue. And I think we're ready to go on to metabolism. Let me see if I went one too many. Hang on. Yeah, I skipped ahead one, so we're here on to metabolism. We talked a lot about this in 112. We know that the liver is doing the main amount of metabolism, and there's this whole set of enzymes, the CYP450 system. The pictures might even be real familiar here, where you're looking at the same ones I used in 112. These are the things, these enzymes are inactivating a drug to get rid of it, or they make changes to it so that the kidneys can excrete it as part of metabolism. It's going to metabolize and increase its therapeutic action. Sometimes that's what's happening. Codeine is converted by the liver to morphine, so then you get an increased therapeutic action. You can have an increase or a decrease in toxicity with the CYP450 metabolism. Some of these CYP interactions you have to think about, like grapefruit juice and St. John's wort. They both affect the system. Grapefruit juice is an inhibitor. That's the red arrow there. So things that need this specific CYP3A4 enzyme to metabolize, it's going to be inhibited by grapefruit juice. So the drug might just be hanging around and not getting metabolized to be excreted out of the body. So then you might be toxic on that. And then St. John's wort, it's an inducer, you see with the green arrow. So the things that need these two enzymes, the CYP2C19 and the 3A4, St. John's wort induces to make more and more of these enzymes. So drugs using those are going to be metabolized very quickly because the dose is going to be all used up, so to speak, so you won't get the therapeutic effect because it's being metabolized much quicker because you have a lot of this enzyme around. Then you have Plavix or clopidogrel, which is an active platelet inhibitor. You see it going across as metabolized by the CYP2C19 enzyme, it gets activated and it doesn't give any therapeutic effect until after it's metabolized. That's the prodrug like we talked about earlier. It needs metabolism to change into a therapeutic drug or to get its therapeutic effect. So we've just reviewed these three actions here. Metabolism of a drug is metabolized by an enzyme, and it turns into a metabolite or breakdown to get out of the body. And then some drugs are inhibitors, so they block or slow down the enzyme from the action. Acute alcohol, like a bender on the weekend, is going to decrease enzymes because the liver's trying to deal with all the alcohol overload it just had. Also inducers, they're going to be stimulating enzymes, so that this is where they create a lot more enzyme than normal, and that can speed up the metabolism of a drug so it's metabolized more rapidly, and then you won't get the therapeutic effect. With chronic alcohol use, also, the body is dealing with being used to all that alcohol that you're already intaking maybe on a daily basis. So it's already making more enzyme to deal with that effect. And so you might have higher levels of enzymes around. Smoking can also cause this increased amount of enzyme. So that with that, maybe you're going to have some drugs you'll need more and some drugs you'll need less because there's a lot of enzyme around, depending on what kind of drug it is. So those are some things to consider about metabolism, the induction or inhibition of enzymes. Either more drug used up quicker so you don't get the therapeutic effect, or you have more drug hanging around so you end up with toxicity. So another one that we need to talk about is first pass. First pass is when you're taking an oral medication and the oral absorption goes in the stomach or the small intestine, and then it gets into the blood right at the hepatic portal vein. And so that blood flow goes right to the liver, and it ends up being metabolized a large amount of the drug right away. So it's not available systemically, and so you get a decreased therapeutic effect. Nitroglycerin is one that's like this. We usually give it sublingually, so it gets absorbed right into the bloodstream and it gets to skip the first pass. Also morphine, the first pass effect metabolizes a lot of it. You might be giving 2 milligrams IV, which works well, and then PO, or the by mouth dose, which is going to have to do the first pass. It might be 10 milligrams because 8 is going to be metabolized away with this first pass effect. If you're giving it IV route, it's going directly to the blood, right? So it doesn't get to the stomach at all or to the hepatic portal vein that way, so there's no first pass. Also, there's competition. There's only so many enzymes the CYP system has at a time with your liver, because your liver's there to take care of filtration and metabolism for our whole body and everything that's going on, not just drugs that we're going to be taking on top of all of our other functions. So you have to have consideration with what's going on with the liver at baseline. Excuse me. If you're giving 2 drugs at the same time that need the same enzyme, there may be some toxicity for one or the other, because there's only room enough for one to be metabolized by that normal amount of enzyme around, or for the reduced amount of enzyme around if you have liver issues. So it's one thing to think about when you're identifying changes in patients with pharmacokinetics. Like maybe here's some things to look up to help you study. If your patient has had a small bowel resection, will they have an increase or a decrease in drug absorption? What if your patient has renal insufficiency? What is going to happen with drugs, and what is going on with the kidneys? So those are a couple of things to help you. If your patient is an alcoholic, what kind of adjustment would need to be made to their medications? Do you think it would be a higher dose needed, or will it be a lower dose needed? Or are there other factors, something else you have to look at, like the type of medication, whether it's an inducer or an inhibitor, or what kind of metabolism is going on. So those are a couple things to help you with your studying. If your patient has poor nutritional status, they're going to have the lower protein amount too, so those drugs that need to be protein bound, they'll have a harder time with that type. Okay, well, let's go on to excretion. The routes of excretion, of course, we make urine, we have saliva, breast milk, we exhale. That's the way alcohol can be excreted. Kidneys are the focus here. The glomerular filtration is the marker for how well the kidneys are working. That's the GFR. So the glomerular filtration rate, man, I stumble that word every time. It's a picture of how healthy the kidney is. You also have passive tubular reabsorption, and in the tubules, as a drug is filtered out of the blood via the kidneys, it can get reabsorbed in the renal tubules. There's active tubular secretion, where some of it's pumped out of the tubules, and some drugs will need this active pump to go from the blood into the urine. There's competition for this kind of active transport, so you can only get so many molecules through with this competition for drugs to be excreted. We can also affect the pH of the urine. Alkaline urine promotes excretion of an acid, and acidic urine would promote excretion of an alkaline or a base substance. So with an overdose of aspirin, which is an acid, you may be giving bicarb, which is a base, so that the aspirin becomes ionized and it's going to get excreted and not reabsorbed. If it's ionized, it doesn't want to be taken up into the cells. With age, that GFR is going to decrease and kidney function decreases, so that affects the way excretion is going to happen in older adults. We need to really monitor our patients that are older and watch for effect, watch for toxicity with those with poor kidney function. If somebody has renal insufficiency, they are going to be at risk for drug toxicity. So on to steady state and half-life. Here you see on this graph across the bottom time in the multiples of half-life. It usually takes 4 half-lives, or between 3 and 5, so we just call it 4. And for testing purposes, you need to know this, that it takes 4 half-lives to reach a steady state, where it becomes effective after 4 half-lives. That reaches its best therapeutic effect. If you have been on a drug and you're waiting for it all to get out of your system, it takes the same, about 4, maybe 5 half-lives to get all the drug out of your system. So look up and do some math here so you can actually figure out what a dosage would be. Look at your 112 notes. Remember, I had this problem. Drug A has a half-life of 2 hours. If the initial plasma level of the drug given as a single dose at noon is 1200 milligrams per liter, what will its plasma level be after 8 hours at 8 p.m.? That is the end of this. Thank you very much for listening. Get yourself a drink before you go on to any more studying or a break. Thank you very much.